Hi, I am Dr. Bhavani Rao, Associate Professor of Surgery, King George Hospital, Vizag, India. I am discussing thyroid diseases starting with its historical background. Goiter originates its name from the Latin gutter, which means throat, and is defined as an enlargement of the thyroid, and it has been recognized since 2700 BC. The term thyroid gland comes from the Greek word thyroideus, which means it is shield-shaped. The most notable thyroid surgeons were Emil Theodor Kocher and Theodor Bildoth. They performed thousands of operations with increasingly successful results. However, as more patients survived these operations, new problems and issues became apparent. After total thyroidectomy, patients, particularly children, became myxedematous with cretinous features. Kocher used the term cachexia struma priva to describe this condition. What is the embryology of thyroid gland? The thyroid gland arises as an outpouching of the primitive foregut around the third week of gestation. It originates at the base of the tongue in the vicinity of the foramen cecum. Endoderm cells in the floor of the pharyngeal enlag thicken to form the medial thyroid enlag that descends in the neck anterior to the structures that form the hyoid bone and larynx. During its descent, the enlag remains connected to the foramen cecum via an epithelial-lined tube known as Thyroglossal cyst. The epithelial cells make up the enlag give rise to the thyroid follicular cells. Paired lateral enlags originate from the fourth branchial pouch and fuse with the median enlag at an approximately 5th week of gestation. The lateral enlags and neuroectodermal in origin, they are ultimobranchial bodies. They provide the calcitonin producing parafollicular cells or C cells. They come to lie in the superior posterior region of the gland. Thyroid follicles are initially apparent by 8 weeks. The colloid formation begins by the 11th week of gestation. Developmental abnormalities of thyroid do occur and give rise to thyroglossal duct sinus and thyroglossal duct cyst. Thyroglossal duct cysts are the most commonly encountered congenital cervical anomalies. During the 5th week of gestation, the thyroglossal duct lumen starts to obliterate and the duct disappears by the 8th week of gestation. Rarely, the thyroglossal duct may persist in whole or in part. Thyroglossal duct cysts may occur anywhere along the migratory path of the thyroid gland. 80% are found in juxtaposition to the hyoid bone. They are usually asymptomatic. Occasionally it becomes infected by oral bacteria. Thyroglossal duct sinus results from infection of the cyst secondary to spontaneous or surgical drainage of the cyst. Histologically, thyroglossal duct cysts are lined by pseudostratified ciliated columnar epithelium and squamous epithelium with heterotrophic thyroid tissue present in 20% of cases. The diagnosis is usually established by observing a 1 to 2 cm smooth, well-defined midline neck mass that moves upwards with protrusion of the tongue. Understanding the embryology gives an insight to the position of the lingual thyroid, suprahyoid thyroglossal cyst, tract of thyroid descent and of the thyroglossal fistula, thyroglossal cyst or ectopic thyroid, pyramidal lobe and retrosternal goiter. Treatment of thyroglossal duct cyst and sinus involves the Sistrunk operation. It consists of en bloc cystectomy and excision of the central hyoid bone to minimize recurrence. What is a lingual thyroid? A lingual thyroid represents a failure of the median thyroid enlag to descend normally and may be the only thyroid tissue present. Intervention becomes necessary for obstructive symptoms such as choking, dysphagia, airway obstruction, and hemorrhage. Many of these patients develop hypothyroidism. Medical treatment options include administration of exogenous thyroid hormone to suppress TSH and radioiodine ablation followed by hormone replacement. Surgical excision is rarely needed, but if required, should be preceded by an evaluation of normal thyroid tissue in the neck to avoid inadvertently rendering the patient hypothyroid. What is an ectopic thyroid? Normal thyroid tissue may be found anywhere in the central neck compartment. It includes the esophagus, trachea, and anterior mediastinum. Thyroid tissue has been observed adjacent to the aortic arch in the aortopulmonary window, within the upper pericardium and in the interventricular septum. Often, tongues of thyroid tissue are seen to extend off the inferior poles of the gland and are particularly apparent in large goiters. Thyroid tissue situated lateral to the carotid sheath and jugular vein. They were previously termed as lateral aberrant thyroid. They almost always represent metastatic thyroid cancer in lymph nodes. The differentiation of metastatic papillary carcinoma into the lymph nodes is so perfect that it was confused as an ectopic thyroid tissue. Even if not readily apparent on physical examination or ultrasound imaging, the ipsilateral thyroid lobe contains a focus of papillary thyroid cancer which may be microscopic. Pyramidal lobe. Normally, the thyroglossal duct atrophies, although it may remain as a fibrous band. In approximately 50% of the individuals, the distal end that connects the thyroid persists as pyramidal lobe projecting up from the isthmus, lying just to the left or right of the midline. In the normal individual, the pyramidal lobe is not palpable, but in disorders resulting in thyroid hypertrophy like Graves' disease, diffuse nodular goiter, or lymphocytic thyroiditis, the pyramidal lobe is usually enlarged and palpable. Anatomy of thyroid gland. The adult thyroid gland is brown in color and firm in consistency. It is located posterior to the strap muscles. The normal thyroid gland weighs approximately 20 grams. But the gland weight varies with the body weight and iodine intake. The thyroid lobes are located adjacent to the thyroid cartilage and connected in the midline by an isthmus, which is typically located just anterior to the cricoid cartilage. A pyramidal lobe, which represents the most caudal end of the thyroglossal duct, is found in approximately 50% of the individuals having thyroid operations. The thyroid lobes extend to mid-thyroid cartilage superiorly and lie adjacent to the carotid sheaths and sternocleidomastoid muscles laterally. The strap muscles, which includes sternohyoid, sternothyroid, and superior billy of omohyoid, are located anteriorly and are innervated by the ansa cervicalis or ansa hypoglossi. The thyroid gland is enveloped by loosely connecting fascia that is formed from the partition of the deep cervical fascia into anterior and posterior divisions. The true capsule of the thyroid is thin, densely adherent fibrous layer that sends out septa that invaginate into the gland. It forms the pseudolobules. The thyroid capsule is condensed in the posterior suspensory or Berry's ligament near the cricoid cartilage and upper tracheal links. Why does the thyroid gland move upwards with deglutition? The thyroid lies in the middle layer of the deep cervical fascia and is attached from its superior medial aspect to the thyroid and cricoid cartilages via the anterior suspensory ligament. Berry ligament, otherwise known as posterior suspensory ligament, connects the posterior medial aspect to the first and second tracheal rings and the cricoid cartilage. When the larynx moves upwards during deglutition, the attached thyroid also moves. The stenohyoid and stenothyroid muscles cover the thyroid gland anteriorly. The tubercle of Jacker-Candle extends off the posterior and lateral aspects of the thyroid lobes. The thyroid gland is well vascularized by two major sets of arteries. The superior thyroid artery arises from the ipsilateral external carotid artery and divide into anterior and posterior branches at the apices of the thyroid lobes. The inferior thyroid arteries are derived from the thyrocervical trunk shortly after their origin from the subclavian arteries. The inferior thyroid arteries travel upwards in the neck posterior to the carotid sheath to enter the thyroid lobes at their midpoint. A thyroid artery arises directly from the aorta or innominate in 1 to 4% of individuals. It enters the isthmus or replaces a missing inferior thyroid artery. The inferior thyroid artery is intimately associated with recurrent laryngeal nerve. It necessitates the identification of recurrent laryngeal nerve before the arterial branches can be ligated. Venous drainage of the thyroid gland occurs via multiple small surface veins which coalesce to form three sets of veins: the superior, middle and inferior thyroid veins. The superior thyroid vein runs with the superior thyroid artery bilaterally. The middle thyroid vein or veins are less consistent. The superior and middle thyroid veins directly drains into the internal jugular veins. The inferior veins often form a plexus which drains into the brachiocephalic veins. The neck anatomy viewed from behind demonstrates the neurovascular structures related to the thyroid gland. The superior thyroid artery takes origin from the external carotid artery. The inferior thyroid artery arises from thyrocervical trunk of the subclavian artery. The left recurrent laryngeal nerve arises from the vagus nerve where it crosses the aortic arch, loops around the ligamentum arteriosum and ascends medially in the neck within the tracheoesophageal groove. The right recurrent laryngeal nerve arises from the vagus at its crossing with the right subclavian artery. The nerve passes posterior to the artery before ascending in the neck, its course being more oblique than on the left side. Generally, parathyroid glands can be found within 1 cm of the junction of the inferior thyroid artery and the recurrent laryngeal nerve. The superior glands are usually located dorsal to the recurrent laryngeal nerve, whereas the inferior glands are usually found ventral to the recurrent laryngeal nerve. The recurrent laryngeal nerves innervate all the intrinsic muscles of the larynx except the cricothyroid muscles. The cricothyroid muscles are innervated by the external laryngeal nerves. Injury to the one recurrent laryngeal nerve leads to paralysis of the ipsilateral vocal cord, which comes to lie in the paramedian or abducted position. The paramedian position results in a normal but weak voice, whereas the abducted position leads to a hoarse voice and an ineffective cough. Bilateral recurrent laryngeal nerve injury may lead to airway obstruction, necessitating emergency tracheostomy or loss of voice. If both cords come to lie in an abducted position, air movement can occur, but the patient has an ineffective cough and is at increased risk of repeated respiratory tract infections from aspiration. Recurrent laryngeal nerves. Along their course in the neck, the recurrent laryngeal nerves may branch and pass anterior, posterior or interdigitate with branches of the inferior thyroid artery. The right recurrent laryngeal nerve may be non-recurrent in 0.5 to 1% of individuals and is often associated with a vascular anomaly in this situation. Non-recurrent left recurrent laryngeal nerve are rare but have been reported in patients with situs inversus and a right-sided aortic arch. The recurrent laryngeal nerve may branch in its course in the neck, and identification of a small nerve should alert the surgeon to this possibility. Identification of the nerves or their branches often necessitates mobilization of the most lateral and posterior extent of the thyroid gland, the tubercles of Zuckerkandl, at the level of the cricoid cartilage. The last segments of the nerves often course below the tubercle and are closely approximated to the ligament of Berry. Branches of the nerve may traverse the ligament in 25% of individuals. They are particularly vulnerable to injury at this junction. The recurrent laryngeal nerves terminate by entering the larynx posterior to the cricothyroid muscle. The superior laryngeal nerves also arise from the vagus nerves. After their origin at the base of the skull, these nerves travel along the internal carotid artery and divide into two branches at the level of hyoid bone. The internal branch of the superior laryngeal nerve is sensory to the supraglottic larynx. Injury to this nerve is rare in thyroid surgery, but its occurrence may result in aspiration. The external branch of the superior laryngeal nerve lies on the inferior constrictor muscle and descends along the superior thyroid vessels before innervating the cricothyroid muscle. Cernia and Associates proposed a classification system to describe the relationship of this nerve to the superior thyroid vessels. In the figure above, type 2A variant, in which the nerve crosses below the tip of the thyroid superior pole, occurs in up to 20% of the individuals. It places the nerve at greater risk of injury. Therefore, the superior pole vessels should not be ligated en masse. They should be individually ligated low on the thyroid gland and dissected lateral to the cricothyroid muscle. This nerve also has been called the eminita galla carse or high note nerve after the opera singer. Injury to this nerve leads to the inability to tense ipsilateral vocal cord and hence difficulty in hitting high notes, projecting the voice, and voice fatigue during prolonged speech. Parathyroid glands. Most individuals have 4 parathyroid glands which derive their blood supply primarily from branches of the inferior thyroid artery. Generally, parathyroid glands can be found within 1 cm of the junction of the inferior thyroid artery and the recurrent laryngeal nerve. The superior glands are usually located dorsal to the recurrent laryngeal nerve, whereas the inferior glands are usually found ventral to the recurrent laryngeal nerve. Lymphatic system. The thyroid gland is endowed with an extensive network of lymphatics. Intraglandular lymphatic vessels connect both thyroid lobes through the isthmus. They also drain to perithyroidal structures and lymph nodes. Regional lymph nodes include pretracheal, paratracheal, perithyroidal, recurrent laryngeal nerve, superior mediastinal, retropharyngeal, esophageal, and upper, middle and lower jugular chain nodes. These lymph nodes can be classified into 7 levels as depicted in the figure. The central compartment includes nodes located in the area between the 2 carotid sheaths, whereas nodes lateral to the vessels are present in the lateral compartment. A thorough knowledge of these lymph nodes is needed for the adequate management of patients with thyroid cancers that have a predilection for lymph node metastasis such as papillary and medullary thyroid cancers. Thyroid cancers may metastasize to any of these regions, although metastasis to submaxillary lymph nodes is rare. Thyroid histology. Microscopically, the thyroid is divided into lobules that contain 20 to 40 follicles. There are roughly 3 million follicles in the adult male thyroid. The follicles are spherical and average 30 micrometers in diameter. Each follicle is lined by cuboidal epithelial cells and contains a central core of colloid secreted from the epithelial cells under the influence of the pituitary hormone TSH. The second group of thyroid secretory cells is the C cells or parafollicular cells, which contain and secrete hormone calcitonin. They are found as individual cells or clumped in small groups in the interfollicular stroma as located in the upper poles of the thyroid lobes. Thyroid physiology and iodine metabolism. The average daily iodine requirement is 0.1 milligram, which can be divided from foods such as fish, milk and eggs, or additives in bread or salt. In the stomach and jejunum, iodine is rapidly converted to iodide and absorbed into the bloodstream, from where it is distributed uniformly throughout the extracellular space. Iodide is actively transported into the thyroid follicular cells by an ATP-dependent process. In fact, the thyroid is the storage site of greater than 90% of the body's iodine and accounts for 1/3 of the plasma iodine loss. The remaining plasma iodine is cleared via renal excretion. Thyroid hormone synthesis, secretion and transport. The synthesis of thyroid hormone consists of several steps. The first step, iodide trapping, involves active ATP-dependent transport of iodide across the basement membrane of the thyrocyte via an intrinsic membrane protein, the sodium iodine symporter NIS. Thyroglobulin Tg is a large 660 kilodalton glycoprotein. It is present in thyroid follicles. It has 4 tyrosyl residues. The second step in thyroid hormone synthesis involves oxidation of iodide to iodine and iodination of the tyrosine residues on thyroglobulin. It forms monoiodotyrosines, that is MITs, and diiodotyrosines, that is DITs. Both processes are catalyzed by thyroid peroxidase. The recently identified protein pindrin is thought to mediate iodine efflux at the apical membrane. The third step leads to the coupling of 2 DIT molecules to form tetraiodotyrosine or thyroxine, that is T4, and 1 DIT molecule with 1 monoiodotyrone molecule to form 3,5,3-triiodotyrosine or T3, or reverse 3,5-triiodotyrosine, that is RT3. When stimulated by TSH, thyrocytes form pseudopodia that encircles portions of the cell membrane containing thyroglobulin, which in turn fuse with the enzyme containing lysosomes. In the fourth step, thyroglobulin is hydrolyzed to release free iodothyronines, that is T3 and T4, and mono and diiodotyrosines. The latter are deiodinated in the fifth step to iodide, which is reused in the thyrocyte. In the euthyroid state, T4 is produced and released entirely by the thyroid gland, whereas only 20% of the total T3 is produced by the thyroid. Most of the T3 is produced by peripheral deiodination, that is removal of 5-iodine from the outer ring of the T4 in the liver, muscle, kidney and anterior pituitary, a reaction that is catalyzed by 5-monodeiodinase. In conditions such as Graves' disease, toxic multinodular goiter or stimulated thyroid gland, the proportion of T3 released from the thyroid may be dramatically elevated. Thyroid hormones are transported in the serum bound to carrier proteins such as thyroxine binding globulin, that is TBG, and thyroxine binding prealbumin, that is TBPA, and albumin. Only a small fraction, that is 0.02% of thyroid hormone T3 and T4 is free, that is unbound, and it is this form that is physiologically active component. T3 is the more potent of the two thyroid hormones, although its circulating plasma level is much lower than that of T4. T3 is less tightly bound to protein in the plasma than is T4, and so it enters tissues more readily. T3 is 3 to 4 times more active than T4 per unit weight, with a half-life of about 1 day compared to approximately 7 days for T4. The secretion of thyroid hormone is controlled by the hypothalamic-pituitary-thyroid axis. The hypothalamus produces a peptide, the thyrotrophin releasing hormone, otherwise known as TRH, which stimulates the pituitary to release TSH or thyrotrophin. TRH reaches the pituitary via the portovenous circulation. TSH, a 28 kilodalton glycoprotein, mediates iodide trapping, secretion and release of thyroid hormones, in addition to increasing the cellularity and vascularity of the thyroid gland. The TSH receptor belongs to a family of glycoprotein coupled receptors that has 7 transmembrane spanning domains and utilize cyclic AMP in the signal transduction pathway. TSH secretion by the anterior pituitary also is regulated by the negative feedback by T4 and T3. Because the pituitary has the ability to convert T4 to T3, the latter is thought to be more important in this feedback control. T3 also inhibits the release of TRH. The thyroid gland is also capable of autoregulation. It allows it to modify its function independent of TSH. As an adaptation to low iodine intake, the gland preferentially synthesizes T3 rather than T4, thereby increasing the efficiency of secreted hormone. In situations of iodine excess, iodine transport, peroxide generation, synthesis and secretion of thyroid hormones are inhibited. Excessively large doses of iodide may lead to initial increased organification followed by suppression, a phenomenon called Wolff-Chaikoff effect. Epinephrine and human chorionic gonadotropin hormones stimulate thyroid hormone production. Thus, elevated thyroid hormone levels are found in pregnancy and in gynecological malignancies such as hydatidiform mole. In contrast, glucocorticoids inhibit thyroid hormone production. In severely ill patients, peripheral thyroid hormones may be reduced without a compensatory increase in TSH levels, the sick euthyroid low T3 syndrome. Thyroid hormone function. Free thyroid hormone enters the cell membrane by diffusion or by specific carriers and is carried to the nuclear membrane by binding to specific proteins. T4 is deiodinated to T3 and enters the nucleus via active transport, where it binds to the thyroid hormone receptor. The T3 receptor is similar to the nuclear receptors of glucocorticoids, mineralocorticoids, estrogens, vitamin D and retinoic acid. In humans, two types of T3 receptor genes are located on chromosome 3 and 17. Thyroid hormones affect almost every system in the body. They are important for fetal brain development and skeletal maturation. T3 increases oxygen consumption, basal metabolic rate and heat production by stimulation of sodium potassium ATPase in various tissues. It also has a positive inotropic and chronotropic effect on the heart by increasing transcription of the calcium plus 2 ATPase in the sarcoplasmic reticulum and increasing levels of beta adrenergic receptors and concentration of G proteins. Myocardial receptors are decreased and actions of catecholamines are amplified. Thyroid hormones are responsible for maintaining the normal hypoxic and hypercapnic drive in the respiratory center of the brain. They also increase gastrointestinal motility, leading to diarrhea in hypothyroidism and constipation in hypothyroidism. Thyroid hormones also increase bone and protein turnover and the speed of muscle contraction and relaxation. They also increases glycogenolysis, hepatic gluconeogenesis, intestinal glucose absorption, and cholesterol synthesis and degradation. How do you evaluate patients with thyroid disease, and what are the tests of thyroid function? A multitude of different tests are available to evaluate thyroid function. No single test is sufficient to assess thyroid function in all situations, and the results must be interpreted in the context of patient's clinical condition. TSH is the only test necessary in most patients with thyroid nodules that clinically appear to be euthyroid. Serum TSH. The test for serum TSH, the normal being 0.5 to 5 microunits per ml. The amount of serum TSH is proportional to the amount of blood secondary antibody. Older radioimmunoassays for TSH were able to detect elevated TSH levels in hypothyroidism, but were not sensitive enough to detect suppressed levels of TSH characteristic of hyperthyroidism. New or second generation sensitive TSH assays can measure levels less than 0.1 unit per ml, and third generation or supersensitive or ultrasensitive assays can detect TSH levels as low as 0.01 units per ml. Serum TSH levels reflect the ability of the anterior pituitary to detect free T4 levels. There is an inverse relationship between the free T4 level and logarithm of the TSH concentration. Small changes in free T4 lead to a large shift in TSH levels. Thus, the ultrasensitive TSH assay has become the most sensitive and specific test for the diagnosis of hyper and hypothyroidism and for optimizing T4 replacement and suppressive therapy. Then, total T4 and total T3. Total T4, which has a reference range of 55 to 150 nanomolars per liter, and T3, which has reference range from 1.5 to 3.5 nanomolars per liter. These levels are measured by radioimmunoassay and measure both the free and bound components of the hormones. Total T4 levels reflect the output from the thyroid gland, whereas T3 levels in the non-stimulated thyroid gland are more indicative of peripheral thyroid hormone metabolism and are therefore not generally suitable as general screening test. Total T4 levels are increased not only in hypothyroid patients but also in those patients with elevated thyroglobulin levels secondary to pregnancy, estrogen progesterone use or congenital disease. Similarly, total T4 levels decrease in hypothyroidism and in patients with decreased thyroglobulin levels caused by anabolic steroid use and by protein losing disorders such as nephrotic syndrome. Individuals with these latter disorders may be euthyroid if their free T4 levels are normal. Measurement of total T3 level is important in clinically hyperthyroid patients with normal T4 levels who may have T3 thyroidoxicosis. Total T3 levels are often increased in early hypothyroidism. Free T4 and free T3 levels. These radioimmunase based tests are a sensitive and accurate measurement of biologically active thyroid hormone. Free T3, which has reference range of 12 to 28 picomolars per liter, estimates are not performed as a routine screening tool in thyroid disease. Use of this test is confined to cases of early hyperthyroidism, in which total T4 levels may be normal but free T4 levels are raised. In patients with end organ resistance to T4, as in Refitoff syndrome, T4 levels are increased but TSH levels are usually normal. Free T3 with a reference range of 3 to 9 picomolars per liter is most useful in confirming the diagnosis of early hyperthyroidism, in which levels of free T4 and free T3 rise before total T4 and T3. Then thyrotrophin releasing hormone. Thyrotrophin releasing hormone. This test is useful to evaluate pituitary TSH secretory function and is performed by administering 500 micrograms of TRH intravenously and measuring TSH levels after 30 to 60 minutes. In a normal individual, TSH levels should increase at least 6 microinternational units per ml from the baseline. This test was also previously used to assess patients with borderline hyperthyroidism but has largely been replaced by sensitive TSH assays for this purpose. Then thyroid antibodies. Thyroid antibodies include anti-thyroglobulin, that is anti-TG, anti-microsomal or anti-thyroid peroxidase, that is anti-TPO, and thyroid stimulating immunoglobulin, that is TSI. Anti-TG and anti-TPO antibody levels don't determine thyroid function. Instead, they indicate the underlying disorder, usually an autoimmune thyroiditis. Approximately 80% of patients with Hashimoto's thyroiditis have elevated thyroid antibody levels, but levels may be also increased in patients with Graves' disease, multinodular goiter, and occasionally with thyroid neoplasms. Then serum thyroglobulin. Thyroglobulin is normally released into circulation in large amounts but increases dramatically in restrictive process of thyroid glands such as thyroiditis or overactive states such as Graves' disease and toxic multinodular goiter. The most important use of serum thyroglobulin levels is in monitoring patients with differentiated thyroid cancer for recurrence, particularly after total thyroidectomy and radioactive iodine ablation. Thyroid imaging, which includes radionuclide imaging. Both iodine 123 and iodine 131 are used to image the thyroid gland. Iodine 123 emits low dose radiation, has a half-life of 12 to 14 hours and is used to image lingual thyroids and goiters. In contrast, 131 iodine use leads to high dose radiation exposure and has half-life of 8 to 10 days. Therefore, this isotope is used to screen and treat patients with differentiated thyroid cancers for metastatic disease. The images provide information not only about the size and shape of the gland but also the distribution of functional activity. Areas that trap less radioactivity than the surrounding gland are termed cold, whereas areas that demonstrate increased activity are termed hot. The risk of malignancy is higher in cold lesions, that is about 15 to 20%, than in hot or warm lesions, less than 5%. Technetium-99 pertechnate is taken up by the thyroid gland and also used for thyroid evaluation. This isotope is taken up by the mitochondria but is not organophile. It also has the advantage of having a shorter half-life and minimizes radiation exposure. It is particularly sensitive for nodal metastasis. More recently, 18-fluorodeoxyglucose positron emission tomography, that is FDG PET, has been used to screen for metastasis in patients with thyroid cancer, in whom other imaging studies are negative. However, this technique is expensive and not widely available. Ultrasound imaging of thyroid gland. Ultrasound is an excellent non-invasive and portable imaging method for studying the thyroid gland. It has the added advantage of no radiation exposure. It is helpful in the evaluation of thyroid nodules, distinguishing solid from cystic ones and providing information about size and multicentricity. Ultrasound also can be used to assess for cervical lymphadenopathy and to guide fine needle aspiration biopsy. However, it cannot be used to image thyroid tissue outside the neck, that is, to assess the extent of a substernal goiter. Other imaging modalities like CT and MRI scan. These studies provide excellent imaging of the thyroid gland and adjacent nodes and are particularly useful in evaluating the extent of large fixed and substernal goiters and their relationship to airway and vascular structures. No contrast CT scan should be obtained in patients who are likely to require subsequent radioactive iodine therapy. Thank you for viewing. Please view other parts of the thyroid also.